So the important part here, though, is what we're here to talk about, which is how do you translate this and how do you get this paid for, or how do you make it into a service line? And what we can tell you is that while this work with cognitive impairment was going on, we were rolling out or working with Aetna, in particular, an insurer, to find out if we could successfully test this in the real world. And what it required was actually, doing this with their case management group at this particular insurer. And we learned a lot of lessons along the way, some of which are summarized in our blurb in the packet. But I will tell you, one of the first things we ran up against is that insurers don't touch patients. Oops. So how can they provide this service? So we had to come up with a new way of how they were going to pay for this as a service to do this testing of it in the real world. And therefore, we had to work with a home care agency and offer this as a service to those particular insurance patients that were eligible in the Medicare Advantage program. We were able to replicate clinical and economic outcomes that were similar to our previous work. And therein we had an independent assessment to determine what the facilitators and barriers were to actually implementing this transitional care model in the real world with Aetna. And we had outside people who knew the work but weren't on our team do this because we thought we knew what the barriers were, and we were pretty on target, but it was nice to be able to have somebody from the outside come in and talk with the people providing the care, the case managers at the insurance company, the nurses who were providing it from the home care agency, and so forth. And that has been published, and I'm happy to give that reference out. I'm sorry I didn't put this on the slide. What was great, though, was that our health system, the University of Pennsylvania, then established the transitional care model as a service line. So it is now offered through our home care agency, which is part of our umbrella of services, which is Penn Care at Home. And Aetna and Independence Blue Cross now reimburse for this. So we now have a screener in the hospital who screens for patients with the particular health plans that Aetna and IBC have agreed to be covered under this using our high-risk criteria. If they meet those criteria, they're offered this as a program for home care through our home care agency, and that has been going on for a couple of years now. And recently, with our new results, we've been able to go back to the insurance. At least one insurance company has agreed so far, but we are in the process of adding the other to include patients with cognitive impairment now that we have these results that show that it is effective, at least in terms of time to first readmission or death and rehospitalizations. So I think that's it. Okay.
Well, I should talk a little bit about the ancestry of this particular project, because I think these projects all have sort of a pedigree. They don't just fall out of the sky. And the ancestry here is that we were doing work on geriatric syndromes, and this project very much comes out of that geriatric syndrome, under recognition of common geriatric problems, the fact that most older adults are taken care of in primary care. And we had been doing some ClinEpi studies using some of our large databases just to see how often substance abuse, depression, cognitive impairment, falls, some common geriatric syndromes were recognized and treated in primary care, and when they were recognized, what type of evaluations or treatments were people getting. And so we had done some clinical trials trying to improve the outcomes for depression, and we excluded people with cognitive impairment in those studies, particularly people with dementia, primarily for the methodologic issues, but also for IRB issues. And several of the geriatricians and the geriatric psychiatrists were not happy about that and started a drumbeat about why didn't we start looking more at intervention studies in dementia. The other ancestry of this project is at the time we were designing this, I was part of the impact study, the collaborative care for late life depression, and it also excluded older adults with dementia. And it was another opportunity to think about how we might improve the recognition and treatment of dementia and Alzheimer's disease in particular. you don't really need to read the box because the box is there to be facetious a little bit, but there's 10 or 11 things there that were the guidelines for the care of dementia in primary care, none of which is feasible in any primary care practice that I've ever been in. The first of which is active screening, which would really get you started. But then you've already, you can see down there's this notion of connecting people with community services as if it were a button, that they're connected. And so we were quite cynical about how this could happen in a primary care setting. And this is still a debate. I think if we had a group of neurologists and primary care docs and geriatricians and geriatric psychiatrists and the rest of the healthcare team, there's still a debate about whether this is the most appropriate setting to deliver this kind of care to these folks. Having said that, there are very few alternatives. This is where older people come. This is where you have their attention. So the collaborative care program was care management by a nurse practitioner. As I said, it had its origins in the impact study. But the key here is that that nurse practitioner is embedded in the primary care doc's office. And so if they're embedded, if the primary care doc takes responsibility for them in terms of their success. So the primary care doc would like whatever success that advanced practice nurse has to reflect back on them, that they're running a very nice practice. And if you can accomplish that, you can get a nice marriage going between what the nurse practitioner can do and what the primary care doc can do. The other is, you've heard a lot today that you simply have to do longitudinal tracking. I've put up here behavioral symptoms, but really, where are these people? Who is the caregiver today? You thought they moved to Arkansas, but now they've moved back to Indianapolis. Just keeping track of people is a lot of work, let alone you have behavioral symptoms and then you have their other chronic conditions. The other thing the nurse practitioner did, which is really hard to capture, measure, and report in terms of fidelity of an intervention or how an intervention is tailored, is this ombudsman's role, which is completely different for every patient and it changes over time. So, going into a home on one day and making arrangements to have, say, a ramp put in over the front steps might have been the intervention that had the effect for any given patient. Someone else, it might actually have been the cholinesterase inhibitor, and trying to tease apart which actually did what for which person is really hard. There was also a clinic-based support group. I know many of you know Mary Ostrom, but one of the things that we had trouble with is getting the people from that we had assembled from a primary care practice to go to a support group which was in a different neighborhood or with a different group of people than they were used to being around. And so the support group happened right in the primary care office in a community room there. And then we had referral to Alzheimer's Association, but it was mostly getting people signed up for Safe Return. Now, they had access to Alzheimer's after that, but it wasn't nearly as proactive as some of the interventions you've heard about this morning, or maybe the UCLA Barbara Vickery's intervention, where it was a really strong effort to get people hooked with community services. And so this is the package, and I'll bet it's, while it describes everyone, it describes no one. Those are all very generic type interventions. It's a very well-trained nurse practitioner, and we say do good and kind of figure out what people need, and they help people navigate the system. Now, that worked. What I want to switch to very quickly is, if it worked, why doesn't everybody have it in their neighborhood? And I I tried to get a picture of my son up here, but it probably would have crashed the computer. So he was 11 when I started on this. The AHRQ proposal was actually written in 1999. Of course, it went through some revisions. And my son is now 25. And we were recently funded by CMSI, which I think will be the first credible chunk of money to actually implement this in the way someone launching a Hollywood movie might say you had implemented something, or a drug company might implement something. And then the other thing I'm trying to show here is these little, incremental steps to keep this alive and to keep moving it along for either making it more powerful or more integrated, more practical from the healthcare system's perspective. A lot of time has passed. And all of the people who said that would never work now say, well, of course it worked. And still it's not out there. So this kind of shows you the amount of effort. The other thing that I want to say, and I think it's on this next slide, well, let me say it here first. There's no particular reason besides that research project that ended in 2005, and really the manuscript is part of that. Everything else I have no particular aptitude for. There's no reason why I should be able to market a project like this. It's not like I took a training class in marketing, or, that I've worked in the pharmaceutical industry and I know how to launch something. I don't know how to raise, millions of dollars in investment capital. And as I do that, or as any of you do that, I'm disengaged from the next projects, which would have been, okay, it worked, but make it better, like other people might do. At the same time, I think many of the people that have told you about their implementation effort, somebody gets, even though nobody's responsible for any one of these projects, we're all working in teams, somebody gets associated with it. And whoever is trying to disseminate it wants the inventor. And then it's dead, because that inventor has such a small capacity to actually go out and sell this. So I think that problem with our training and our aptitude to do this, if you couple it with saying, well, it has to be you, it's a real problem. So the evidence for cost savings we were supposed to comment on, I don't even think the nurse practitioner covers a third of her cost. In fact, the effort that it takes for her to bill is probably not even worth it because of the documentation that has to go on. She probably could have made, another visit in that time. I mean, we do have situations, especially in Indiana, where the nurse practitioner can bill, but it's not going to cover her time. So all of our arguments after the research, after we show it works, have to do with downstream savings. And in order to make this argument, you have to be in the boardroom. And this is another thing that we're not particularly well trained for. It's a different language. They use the same words that have different meanings. And they have a timeline that's completely unheard of in research. And they're not interested in any of your articles or any of that kind of business. And it takes, again, it's an investment in time to learn that language. So this is how we're selling it now, is in these downstream savings. And if you want to go to the state, you simply can't talk to them if you're not talking about delay in nursing home use. And actually, the last time they completely flipped it when I went to talk to them, and they wanted me to get people out of the nursing home. So it's a whole nother level. Thank you.